I will be covering pelvic neuroanatomy and common pelvic nerve injuries. Nerve injuries occur in about 2% of pelvic surgeries. The prevalence is influenced by the type of surgery, the surgical approach, the position of the patient, and the duration of surgery. Symptoms experienced by the patient can be reversible or permanent, and symptoms include motor weakness or sensory deficit in the area of the involved nerve, and transection injuries can result in pain. The causes of nerve injury can be transection of nerves, such as in incisions, trocar placement, or electrosurgical devices, can be from nerve entrapment from ligation for hemostasis or tissue reapproximation, and can be from reconstructive pelvic surgery, for example, vaginal or bladder suspension surgeries. In nerve injury can also be from compression or stretching of the nerves, such as in patient positioning in lithotomy, retractors, clamps, or hematoma formation. Surgical incisions can result in transection nerve injuries. With vertical incisions, there is low risk of nerve injury, and this is due to sensory dermatomes that overlap in the midline. With transverse incisions, data shows that 7% of women have chronic pain post-phalansteal incision, and this is due to entrapment of the iliohypogastric or ilioinguinal nerves. An incision 3 cm above the symphysis pubis and within the borders of the rectal muscle have minimal loss of neural function. Dissection of the anterior rectus sheath may injure terminal sensory fibers, and hemostatic efforts for bleeding perforating vessels may also lead to injury. These are the three common surgical incisions used in gynecology. It's the midline vertical incision, Joel-Cohen, and phalansteal incision. With the midline vertical incision, you can see the sensory dermatomes overlap each other, so there is less risk of nerve injury. The Joel-Cohen incision should be 3 cm above the pubic symphysis and within the borders of the rectus muscle. And with the phalansteal incision, it's lower down in the abdomen, and there is risk of cutting or transecting the anterior branches of the iliohypogastric nerve. We will now look at some individual pelvic nerves, the first one being the ilioinguinal nerve. It's from the L1 nerve root, and it rises from the lateral edge of the psoas muscle. It courses over the iliacus and quadratus lumborum muscle and travels down into the pelvis through the superficial pelvic ring. On the anterior abdominal wall, it can be found 3 cm medial and 3.5 cm inferior to the anterior superior iliac spine, and 3 cm lateral to the midline and 2 cm superior to the pubic symphysis. The sensation function includes transverse abdominis muscle and internal oblique muscles, the skin over the external genitalia and anterior medial thigh, and its motor function includes innervation to the transverse abdominis and internal oblique muscles. The iliohypogastric nerve is from T12 and L1 nerve root. It arises from the upper lateral border of the psoas muscle. It crosses in front of the quadratus lumborum to an area superior to the iliac crest. On the anterior abdominal wall, it can be found 2 cm medial and 1 cm inferior to the anterior superior iliac spine, and 4 cm lateral to the midline and 5 cm superior to the pubic symphysis. Its sensory function includes the superior gluteal region and part of the suprapubic region, and motor function to the internal oblique muscle. The causes of iliohypogastric and ilioinguinal nerve injuries include entrapment by sutures at the lateral poles of transverse fascial incisions for hernia repairs, direct trauma, or formation of a neuroma during normal scarring process. The triad of symptoms include a sharp burning pain radiating from the incision to the suprapubic area, labia, or thigh, paresthesia over these areas, and pain relief after infiltration with local anesthesia, and the symptoms are aggravated by stretching, coughing, sneezing, and the Valsalva maneuver. The femoral nerve is from the L2 to L4 nerve root. It arises inferior to the psoas muscle, and it passes underneath the inguinal ligament to enter the femoral triangle. It's found lateral to the femoral vessels. Its sensory function includes the anterior medial thigh, medial leg and foot, and motor function is muscles of the anterior thigh, so those are the hip flexors and knee extenders. Injuries to the femoral nerve can occur during deep pelvic surgery, especially abdominal hysterectomy, and the mechanism is from compression of the nerve against pelvic sidewall as it emerges from the border of the psoas muscle before exiting the pelvis at the inguinal ligament. Most femoral neuropathies resolve spontaneously. The risk factors for compression are a wide phalansteal incision, a thin subcutaneous layer, a surgery time more than 4 hours, poorly developed rectus muscle, narrow pelvis, and self-retaining retractors with extreme lateral traction. The genitofemoral nerve is from the L1 to L2 nerve roots. It pierces and then runs over the belly of the psoas muscle, lateral to the external iliac vessels. It splits into the genital and femoral branches, and it only has a sensory function. The femoral branch is to the anterior upper thigh, and the genital branch is to the mons pubis. The lateral femoral cutaneous nerve is from the L2 to L3 nerve roots. It arises from the lateral edge of the psoas muscle and courses over the iliacus muscle towards the inguinal ligament. Its sensory function includes lateral skin of the thigh. Injury to these two nerves includes compression injury from the retractor blades or transection injury from dissection of external iliac lymph nodes, mobilization of the iliac vessels, or removal of a large pelvic mass adherent to the pelvic sidewall. The obturator nerve is from the L2 to L4 nerve roots. Its fibers unite posterior to the psoas major muscle in the obturator space, which is a space deep and medial to external iliac vessels and lateral to the medial umbilical ligaments. It arises from the medial border of the psoas major muscle and passes inferiorly over the pelvic brim to the obturator canal. It then divides into anterior and posterior branches. Its motor function includes thigh adductor muscles and sensory function to the hip joint and the anterior medial thigh and knee. Procedures associated with obturator nerve injury include a passage of trocar in this area, pelvic lymph node dissection of the obturator fossa, excision of endometriosis, paravaginal defect repair, dissection in the retropubic space, and an obturator bypass in vascular surgery. The results of the injury include numbness of the inner thigh and weakened thigh adduction, leading to minor ambulatory problems. The pudendal nerve is from the S2 to S4 nerve roots. It exits the pelvis through the greater sciatic foramen and re-enters the pelvis via the lesser sciatic foramen to enter the pudendal canal. In the pelvis, it passes behind the lateral third of the sacrospinous ligament and posterior to the ischial spine and lateral to the uterosacral ligament. Its motor function includes various pelvic muscles, including the external urethral and external anal sphincter. Sensory function includes external genitalia, perineum, and perianal skin. Pudendal nerve injury can occur from entrapment or stretching. Entrapment where it passes behind the sacrospinous ligament during sacrospinous ligament fixation or pelvic reconstructive procedures such as uterosacral ligament suspension. Entrapment can also occur with professional cyclists. Stretch-induced neuropathy can be acute during childbirth from overstretched pelvic floor or chronic constipation. Symptoms include pain in the area innervated by the pudendal nerve. Pain increases when sitting. The patient is not awakened by pain, and resolution of pain with administration of a nerve block. Fecal incontinence rarely occurs during unilateral nerve injury due to cross-innervation. There are 5 sacral nerve roots from S1 to S5. The sacral nerve roots lie behind the uterosacral ligament. They join with the lumbosacral trunk to form the sacral plexus. The sacral plexus lies in the back of the pelvis between the piriformis muscle and the pelvic fascia. Anterior to this plexus lies the internal iliac vessels, ureter and rectum. Isolated sacral nerve injuries can occur during uterosacral ligament suspension procedures for pelvic organ prolapse. They have neuropathic symptoms, so post-operative sharp buttock pain and numbness that radiates down the center of the posterior thigh to the popliteal fossa. The symptoms related are due to the placement of the suspension sutures, because the symptoms resolved after removal of sutures in patients who had clinical picture of injury. Another treatment option is gabapentin therapy, but requires 12 to 14 weeks of treatment. Autonomic nerves in the pelvis includes the superior hypogastric plexus, which are sympathetic nerves from the lumbar sympathetic chain and aortic plexus. It's located in the retroperitoneum near L5 and S1 and overlies the aortic bifurcation at the level of the sacral promontory. They form the right and left hypogastric nerves and descends into the pelvis inferior and medial to the ureter and lateral to the uterosacral ligaments, and joins up with the inferior hypogastric plexus. The pelvic splanchnic nerves contain parasympathetic innervation to the hindgut and arise from S2 to S4. They join the hypogastric nerves, which contain sympathetic fibers, to form the inferior hypogastric plexus, which then contains a mixture of fibers. The inferior hypogastric plexus runs in a sagittal plane anterolateral to the rectum, lateral along the vagina to the base of the bladder, and divides into three branches, namely the rectum, the uterus and vagina, and the bladder. Injury to the autonomic nerves can occur during pelvic surgery due to nerve stretching from retraction, thermal damage from cautery, ischemia from blood supply disruption, and inflammation from surgical trauma, and they can result in either urinary retention or incontinence, constipation or fecal incontinence, and sexual dysfunction, and that depends on whether the parasympathetic or sympathetic nerves were injured. So how do we prevent nerve injury? It's important to note any pre-op neurological dysfunction and limitations of movement, for example, arthritic joints or artificial joints. Avoid patient malposition, avoid prolonged lithotomy, avoid extreme Trendelenburg, attention to surgical incisions and planning beforehand, and attention to retractors. Patient malpositioning can cause pressure necrosis and neuropathy. It's an area of medico-legal concern and is the surgeon's responsibility and should not be delegated to anyone else. Once the patient is draped, further movement or positioning should be avoided. Supine patients should be positioned to prevent heels and arms from hard surfaces. If the arms are placed adjacent to the body, fingers should not lie within movable table sections. An arm secured to prevent falling during surgery. Arms at the side should not exceed more than 90-degree angle. The correct lithotomy position includes minimal abduction and external hip rotation. The hips, lateral fibulas, posterior thighs, and heels should be padded. The hips should be 90 degrees and knees 70 to 90 degrees, so moderately flexed and secured. The weight of the lower legs should be directed towards the soles of the feet, and the knee stirrups should be adjusted so that metal edges do not fold over or cut into soft tissue. There are four nerves that are prone to injury in lithotomy. The first one is the sciatic nerve that can occur during hip flexion with knee extension or external hip rotation with knee flexion. The femoral nerve can be compressed at the inguinal ligament, especially in thin patients, or by stretching by hip abduction and external rotation. The peroneal nerve can have excessive pressure just below the knee where the nerve wraps around the lateral fibula, and the posterior tibial nerve can be from excessive ankle dorsiflexion if the foot is in stirrups. The risk of nerve injury and compartment syndrome increases after 4 hours of lithotomy or incorrect positioning. The peroneal nerve injury will result in acute foot drop, so unable to dorsiflex the foot, inversion of the foot, and numbness of the lateral leg and dorsum of foot. The posterior tibial nerve injury will result in difficulty with plantar flexion and toe extension, sensory loss at the back of the leg and sole of foot, and compartment syndrome, which will result in pain out of proportion to clinical signs, weakness and hyperesthesia of the foot and leg, and loss of foot pulses. Steep Trendelenburg position is when the bed is tilted more than 30 to 45 degrees and is often needed in laparoscopic pelvic surgery. It causes brachial plexus injury. To prevent injury, you can use shoulder braces or a gel padded sheet spanning the length of the patient's body with head support, or ankle cuffs to prevent slipping. With regard to surgical incisions, as mentioned earlier, the midline longitudinal incision is less likely to cause nerve injury but has other disadvantages. Transverse incision should be made within the borders of the rectus muscle, and if extension is needed, to curve it towards the head instead of extending it straight, to avoid injury to the ilioinguinal and iliohypogastric nerves, and it should be 3 centimeters above the pubis symphysis. Avoid the use of cautery of perforating vessels if possible to prevent injury to the terminal sensory fibers, and use with care on the lateral pelvic sidewall. Laparoscopic ports placed below the level of the anterior superior iliac spine can cause injury to the ilioinguinal and iliohypogastric nerves. Attention should be paid to the retractors. Lateral retractors should not compress the psoas muscle, and you have to use the shortest possible blade that effectively retracts the abdominal wall. In thin patients, you can use abdominal swabs as padding between the patient and the retractor blade, and inspect the blade position upon insertion and periodically during surgery with intermittent relief of the pressure, especially if you're using self-retraining retractors.